You have all probably seen the shocking headlines about how hard the opiate crisis hit white America. Well, as it turns out, these headlines are misleading. Well, at least as it relates to 2020 data. A new study out shows that African Americans, and particularly African American men, are dying at startling rates from drug overdoses. And wait for it, one of the main drivers is systemic racism. The author of that study joins me coming up next.
Live from Los Angeles, this is the Special Report with Areva Martin.
For the past 20 years, the media has focused on the high death rate among white Americans due to drug overdoses. In this country, the drug overdose issue has now become a Black issue. A new peer-reviewed study found that overdose deaths among Black people jumped from 24.7 per 1,000 people in 2019 to 36.8 per 1,000 people. This rate was 16.3% higher than that of white people. Black people have the second highest overdose rate in 2020. And unsurprisingly, Black men were the most affected. This disparity in overdose deaths did not just show up. It didn't show up out of nowhere. And recently it's been documented that Black men, particularly Black men over 55 years old and older, are at an increased risk of dying by opioid overdose. Today we're asking what's driving this increase in drug overdose deaths, particularly as it relates to Black men, and we're asking how America is responding to this drug overdose deaths. Joining me for my first guest is Dr. Helen Hansen. She's a professor of psychiatry at UCLA. She's also the co-author of this new study addressing the rising overdose rates among African Americans. Good morning, Dr. Hansen.
Good morning.
Thanks so much for joining me. I didn't know any of this. I came across several articles recently about your study, about these startling findings, and I was shocked. You know, African Americans fall into so many categories of being at risk for disease and other issues that, impact our longevity, our quality of life, and unfortunately, death by drug overdose happens to be an additional category where African Americans are at risk. I want to start, though, by talking about the trends that we've seen since the late 1990s. Help us understand what was happening in this country, particularly around prescription drugs.
Thank you for that. Yes, so it's a complicated story, and it's the topic of my forthcoming book, Whiteout: How Racial Capitalism Changed the Color of Opioids in America. So as we know, those of us who've been tracking Black health and well-being over the decades, we know that this overdose crisis, quote unquote, of the late 90s is not the first one. We know that heroin ravaged Black communities in the 60s to 80s. And then, of course, it transformed into a crisis of crack cocaine. And a lot of that had to do with cartels targeting unemployed Black and brown men in big port cities that have always been the focus of the drug trade, illegal drug trade in our country. We also know that there has been a lot of political racialization of what counts as a health crisis versus what counts as a crisis of crime, because in the 60s to 80s, these waves of very harmful drug use weren't framed as a crisis of health. In fact, they led to increases in punitive drug policy that, as I'll explain in a moment, have really accelerated the death rate among Black Americans and brown Americans in the country these past couple of years, and before, but it's become really very concentrated now. So the way that we define a crisis is also racialized. And you alluded to structural racism. That is one of the big mechanisms by which structural racism works. We're also on a whole century of defining illegal drug use as Black and brown addiction and crime, and medicalized legal drug use as a white health problem. And that's quite deliberate. So if we go back 100 years to the period of time when heroin was illegalized, cocaine was illegalized, racial politics were centrally involved in that. And there, in fact, there were articles running in the newspapers at that time by people who were prohibition that specifically reported on cocaine-crazed Negroes in the American South who were attacking their work supervisors. That's 1914 New York Times. There were a lot of reports of Chinese opium dens that were luring unsuspecting white women into sex slavery. And these were the racial images. And then later, Mexican marijuana madness. These were the images that led to the very drug policies that we have today that are so punitive, in contrast to prescribed medical narcotics that by post-World War II era were killing a lot of white Americans. So at the time it was barbiturates, and then later benzodiazepines like Valium and Xanax. These were prescribed drugs that were causing actually much higher death rates at the time than the illegal drugs, but they were in a protected medicalized space, not criminalized, because it was understood the consumers were middle-class white Americans. So we're only seeing a replay of that with the crisis, quote unquote crisis, that started in the late 1990s that had to do with the targeted marketing of OxyContin and a bunch of similar products, newly patented, newly developed, sustained release opioids. And from the very beginning, it was clear that they were designed for a white market. The regulators were not as vigilant about restricting access to them because the market was understood to be white. The manufacturers specifically had a white market in mind and deployed drug reps to predominantly white areas, suburban and rural white areas, to promote the drug. That's very clear. And that's one reason why the uptake of these new opioids was so high in those areas. All of the advertisements, the marketing material that was designed for these new opioids featured white people. And in particular, they tended to feature white women and elderly people because they tend to visit doctors at the highest rates. They tend to have insurance and visit doctors for pain complaints and are seen as, not at risk for addiction. They're kind of the antithesis of what for 100 years our media has promoted as the image of the addicted person.
Well, I want to stop you there, Dr. Hansen. So you just described that 1990s, what I'm going to call the first wave, where we saw this targeted marketing of OxyContin and other opioids to middle-class, predominantly white communities. You talked about the drug reps going into doctors' offices and really targeting white women and elderly people. And then some people describe this second wave that happened around 2012 or so, where you saw the rise in heroin overdose deaths. What happened in this country so you just told us that heroin obviously isn't new to the U.S., and we saw large numbers of people using heroin in the 60s. Why did heroin make a kind of a comeback in the mid-20s, around 2012 or so?
Oh, what an excellent question. This is where the story gets interesting, okay? Because the way the country reacted to that first wave of prescription opioid deaths among white Americans was not to criminalize the users, as they have been doing with illegalized drugs for a century, right? The target of the legal response, the policy response, was not the users. It was prescribers and pharmacists. So for them to have targeted white Americans with punitive drug policies, particularly middle-class insured white Americans that had been targeted with the marketing for OxyContin and sister products, that would have been very unpopular politically, as opposed to cracking down on Black and brown communities, which has been a very safe, very politically popular strategy for many decades. So pharmacists and physicians all of a sudden were subject to very heightened surveillance. And I'm a prescriber myself. I'm a physician, I'm a prescriber, and I saw this shift occur. So for example, now in 50 states, we have drug monitoring programs at the state level. Half of them threaten prescribers and pharmacists with threat of loss of their license and criminal conviction if they don't check a database to see if a patient has gotten a prescription for a narcotic elsewhere in the state before they prescribe. And this is unprecedented. I just have to tell you how different that policy has been than policies regulating prescription of medications for the past 100 years. Wow. And, the AMA, the American Medical Association, a lot of people were up in arms because it was quite restrictive and punitive towards doctors rather than the users. But what that did it did decrease the number of prescriptions, and it really constrained the supply of these new prescription pills, opioid pills. But what it did was it created a huge new market opportunity for heroin cartels.
Oh.
So all of a sudden, heroin cartels saw that there were hundreds of thousands of physically opioid dependent white Americans in small towns, suburban and rural America that had been heavily marketed with OxyContin and sister products. Now they didn't have any supplies. They were going into withdrawal. They were desperate. Heroin cartels moved into these areas. Previously, large port cities had been made the major points of entry for heroin to the country, and the markets had been largest there because it's difficult to smuggle into the country. And so large port cities are easier, right? But the opportunity that the prescription opioid manufacturers opened up when the supplies dried up because of these new restrictions on prescribers was lots of people in smaller towns, rural areas, suburban America looking for heroin. So there was a huge uptick in heroin sales.
So the next phase of that, and that's fascinating, as you said, it does get interesting. So the third wave of this starts around 2015, and then we see the rise in synthetic opioids and the deaths caused by use of these synthetics. So what happened in this third wave to create this, rise in these synthetic drugs?
So this is yet another interesting part of the story. So this is what happens when your major drug policy is to try to crack down on illegal drugs and make a distinction between legal and illegal drugs. So in the midst of attempts to control heroin cartels that were moving into these areas, it became much easier to smuggle synthetic versions of heroin, such as fentanyl and other highly potent synthetic opioids. I'll give you the example of fentanyl. 1/100th the weight of fentanyl will have the same impact on your body as heroin. So you only need 1/100th the amount, the bulk, to smuggle in to have the same sales, essentially, right? Mm-hmm. So you can see what a boon this was for the illegal drug cartels. It was so much easier to smuggle this stuff in. They could then dilute it with a lot of other products, a lot of convenient household items, and then sell it to a large market. So this was incredibly lucrative. And so fentanyl and other highly potent synthetic opioids started to really take off. It began concentrated on the East Coast, but now it's migrated to the West Coast. And there are many cities and smaller towns in the country where if you try to buy heroin, you will only find fentanyl on the market. It's being sold as heroin. And this is, of course, very dangerous because that also means you only need 1/100th the amount to overdose that you need of heroin. So that led to a huge uptick in overdose.
Let's come to where we are now in terms of 2022. Is the market still predominantly dominated by the fentanyl products, these synthetic products, or have we moved into yet like a fourth wave?
That's such a good question. So what we're seeing, especially in Black communities, is a fourth wave that's polysubstance, meaning a mixture of these highly potent synthetic opioids, which in many cities and towns has replaced essentially heroin, and stimulants. And so what we're seeing in the Black communities across the country is a combination of death by overdose from opioids and overdose from stimulants. Both are being sold. It's unclear.
Give us an example of a stimulant, like a street name for a stimulant.
Well, both cocaine and crystal methamphetamine. Okay, so both of those and other stimulants, but those are the two best known. And we're seeing a large uptick in deaths from them because they too can cause overdose when they're taken in large amounts. They can cause heart attack. They can cause stroke, fatal stroke. So there are many ways they also can cause death. The thing that we're seeing is a mixture of people showing up with overdose at emergency rooms that have a mixture of stimulants and opioids in their system. And it's unclear whether people showing up with that combination knew that there were any opioids in what they thought were the stimulants they were taking. So these are such potent opioids.
Let me ask you this, Dr. Hansen. So are these, the fentanyl is a pill, is it? Like, what form are these drugs? And like, are you going to get it in a pill? Are you snorting it? Like,
great question.
Shooting it in your arm like heroin?
All of the above. It can be sold as a powder. It can be sold as a pill. It can actually be sold as a counterfeit pill. So if you go on the market and say, I want to buy OxyContin, right? Because I want to have a factory that was regulated, like a pharmaceutical regulated product. I want to know what's in it. but I'm on the illegal market because I can't get anybody to prescribe it for me. And you buy what you think is a tablet of OxyContin. It very well may be counterfeit. It may be a pill of fentanyl and a lot of other mixed in household products that's formed into a pill and stamped. And the reason what I was saying was these new opioids like fentanyl are so potent that even trace amounts that have accidentally leaked into what is being sold as stimulants can cause overdose. So what's unclear right now, we're still investigating it on the ground, is what are people's intentions when they're going to buy these drugs? Do they think that they're buying just stimulant? Do they think they're just buying an OxyContin tablet? And also the cartels, it's unclear. It may be that these are accidental mixings that are occurring. And it may be that Black people are turning to stimulants because they're afraid of overdose by opioids. And what they don't know when they do that is, number one, there could still be these highly potent opioids mixed into their stimulant supply. And number two, the stimulants taken in large amounts can in themselves cause overdose. So we are into that fourth wave of what we call polysubstance use, and a dangerous, dangerous market where nobody really knows what they're buying.
Right. So we know based on the research that in 2010, the overdose death rates amongst white people was twice as high as Black overdose rates. Now, your new study comes out that says that the Black overdose rates, particularly amongst African-American men, has surpassed that of whites. Yeah. What happened between 2010 and 2020, that 10-year span, that caused the African-American death rate by drug overdose to surpass that of the white overdose death rate?
What an excellent question. So I'm glad you asked about the markets beforehand, because that has a lot to do with the story. And I know we're going to hear from an expert in carceral health, what happens to people, especially Black people who are in jails and prisons. But that has a big part to, so the intersection of mass incarceration. I bet most people who are turned into this show know that Black men are 6 times as likely as white men to be incarcerated, right? 6 times. That's enormous. Similar statistics for Native Americans. Latinx men 3 times as likely as white men to be incarcerated. So we know that mass incarceration is a Black and brown phenomenon by design. Drug policies were designed, and a lot of them based on the racial stereotypes that I just explained over the past century. They were designed to target Black and brown communities. And also I want to mention that the peak in incarceration rates happened in 2008. So this was actually pretty recent. You know, while white Americans were subject to a much more medical kind of response to their overdose problem, and I can tell that story in a moment, but rather than incarcerating the users of these new prescription opioids like OxyContin from the 1990s on, what we did was we created a whole separate treatment track for them. We created a cadre of private doctors with medications for these new white opioid-dependent people, and it was explicitly racialized separate track for them. And then on the other track, we continued with mass incarceration for Black and brown. So that peaked in 2008.
Are you saying that these death rates, this increase in death rates, is tied to mass incarceration? Because
yes, I'll explain.
Dying in prison?
Absolutely. No, let me explain. The period of time, this is really well established in the epidemiology literature, that the period of time of weeks to months right after a person is released from jail and prison, so release period, right? They are exceptionally at high risk for overdose for many reasons. Number one, if you're someone who's been using opioids before you were incarcerated, while you were in prison, your tolerance for opioids went down because you didn't have access to opioids in prison or jail. So you've been in prison or jail for months to years without any opioids. Your body is now naive to opioids, meaning it's almost as if you had never taken them. Your body is very sensitive to opioids. So a much smaller amount of opioid can cause overdose death than if you had taken it while you were using it regularly, because your body builds up. If you use daily, your body will build up a tolerance. It'll take larger and larger amounts of opioids to have the same effect and to overdose you. But if you don't have that, if you're coming out of jail and prison, haven't had opioids in a very long time, a small amount of opioid can cause death. And it's a very stressful period of time. anybody who's been released from jail or prison will tell you is incredibly stressful. You're not eligible for most jobs. You're not eligible for a whole host of government funded programs, including for housing. You generally don't have social services. You don't have access to medical care. Your social networks of support may not be there for you. You don't have anybody to support you on the street. So you're very high risk for relapse. Then you're going to a market that over the past few years has become exceptionally toxic and unpredictable. You don't know what you're buying. You no longer know the people who are dealing you drugs, so you don't know who you can trust. And so all of those things coming together, so you're much more likely to be exposed to fentanyl or one of those synthetic opioids. All of those things coming together have greatly, greatly amplified the risk of overdose death rates for Black Americans and Native Americans. And also the rate is really increased for Latinx as well. So it's a Black and brown problem. And so it's really a convergence of all these things, that we have mass incarceration going strong. Then we have the illegal market turning to fentanyl and these ultra potent opioids that aren't heroin, but are being sold as heroin. So all of these things are coming together to create this very high overdose death rate. And then add to that COVID, right? Because what you'll see from the graphs from my study is that the overdose rate, death rate, it goes from increasing really fast. Yes, there's the graph. It goes, you see that right after 2019, all of a sudden it shoots up. The overdose death rate already rising fast. It's almost like a vertical line going all the way up. COVID, okay? Then you add the fact people under COVID, very unstable housing, right? Very unstable access to any kind of medical care, including addiction treatment. And the drug supply on the street, even more unpredictable, because sometimes law enforcement is cracking down. Sometimes they're not. They're changing their patterns. So the cartels and the dealers always changing strategies. So COVID was exceptionally lethal in this setting.
Yeah, I want to bring in Dr. Erin Parison into this conversation. She is a sociolegal scholar and professor at University of California, Berkeley. Good morning and welcome, Dr. Parison. You have had a chance to look at and review and study this new report out by Dr. Hansen and her colleagues. How does this report intersect with the work that you've been doing around drug treatment policies, and really the U.S.'s response to this rising numbers of drug overdose, particularly amongst African Americans?
Yeah, sure. Good morning, and thank you so much for having me. And I'm introducing Reese because he may move around, my dog. I apologize. What I will say is this. I so appreciated your Areva saying death by overdose, and then Dr. Hansen coming in and saying also we're dealing with structural racism. So in my work, I study the way law shapes our lives, right? Death by racism is really what I would suggest is happening with these numbers. So for all of the reasons why the two of you laid out already, that drug use and drug misuse is such a prominent sort of feature of the day-to-day American way, right? And I can break that down for you more and more across class and across race. This is just a thing that Americans do. Americans use drugs, okay? In addition to that, we have all of these issues around where and how we locate the problem. So, interestingly, moving from the pharmacist and the prescribers to the user as responsible is a huge issue, right? Like we're still ignoring sort of the larger levels of how supply is coming in, from whom to what ends, and geographically, where is that supply concentrated? Those are all larger structural issues that are really, really very closely paralleled with structural racism and structural disinvestment and structural inequality and harm, frankly, in these sites. The second thing I'll say is when you move the pathology to the person instead of the structure, if we're still mirroring everything that we see with respect to structural racism and the pathologization, of the Black user, recovery looks different too. So if you're trying to sort of get off of this hamster wheel, which is what a lot of dependency, misuse, and addictive behaviors look and feel like, right? If you ask someone, are you struggling with addiction? That is one of the things that they will name as part of their experiences. We have to think about who is a sympathetic character. And so a lot of policy is shaped by that, because policy is shaped by legislators that are elected by voters, and we just had our primaries in California. So sort of the public will around who do we see as sympathetic, who do we see as deserving of help, and even helpable, right? Not just like, this is what it's going to be. They wake up and this is what they do, and they being Black people. The idea that they can be saved is one that isn't reserved for Black folks. So even as we're thinking about how do we heal from this, there needs to be in the US a reimagination of everyone's humanity, which asks us to interrogate why people use these drugs that are so dangerous in the first place. And if we can then take that anchor to think about, okay, what are we going to do about it? Even if we're locating the pathology at the person, we can look more equitably across class, across gender, and across racial lines to see what kinds of supports and interventions are appropriate. Right now, sort of the blanketed, you're using, that's illegal, you got to go. It's not working for 1,001 reasons, which we can talk about this morning.
Yeah, it's interesting. Both of you are teaching at universities in California, and you're right, Dr. Kerrison, yesterday was election day in California. And we saw a couple of things happen. We saw the district attorney in San Francisco was recalled, and many see that his election as a referendum on police reform, policies and the focus on police reform that we all experienced after George Floyd's murder. That's clearly not telling the whole story about what happened in California, because there were some progressive district attorneys who did very well in yesterday's election also. But there is this narrative, Dr. Hansen, which is being even reiterated by the President of the United States, Joe Biden, that we've got to get tough on crime. That crime is such a big issue in big cities from New York to Los Angeles. And if Democrats want to be elected, they also have to start addressing crime. And we know that the tough on crime message is code for the policies that we have seen in the 90s. And now we have prominent Democrats using that language, reverting, because we're so unimaginative in this country when it comes to criminal justice and when it comes to public safety. So whenever there's a spike in crime, whether it's property crime or violent crime, the default is lock up more people, and the more people are clearly Black and brown people. Give them longer sentences, give them enhancements on their sentences, and basically throw away the key. So are you concerned that this move that's happening in California, is, according to the pundits, and across the nation, is going to result in some of those punitive sentencings and just approach to drug users, even though right now the conversation is on violent crime, not necessarily associated with drugs, and on these property crimes? Everybody's going crazy because somebody stole someone's watch in Beverly Hills. That's like, oh my God, we've got to change our whole criminal justice system. And not that I'm dismissing crime or suggesting that we shouldn't be concerned, because Black folks, we want safe streets and communities as well. But this language is really troubling me. And someone that works in drug policy, how are you feeling about this shift that's happening? I think you're on mute, Dr. Hansen.
Oh, okay. When you said someone is working on criminal justice, I thought you were referring to Dr. Kerrison, because she will have a lot to say. She's a scholar of criminal legal systems.
You work in
but I'll tell you.
I want to hear both of your responses.
Sure. So I'll tell you as a
back to the 90s in terms of how we treat addicted people.
Yes, right. So I'll tell you as a scholar and researcher and a physician of structural racism in health, that Dr. Kerrison is right on point when she's saying this is it's a crisis of racism, not structural competency. And one of the not a crisis of overdose deaths alone. And one of the pitches that I make in my travels is that what we saw with the quote unquote overdose crisis, which was seen to be a white crisis for so long, was the ways that structural racism also kills white people. It's literally, a matter of our survival as a country because structural racism takes so many forms. One of the things that it does is it feeds into this fantasy that at least white people can protect themselves from all these things by offloading to Black and brown. Just lock them up, incarcerate them. That will protect us from the corporations that are marketing highly toxic substances. It'll protect us from a for-profit healthcare system. One of the reasons why we spend the most per capita on healthcare of any country in the entire world, and we have the worst health outcomes of any industrialized nation, is that we're so profit-oriented, and all of our, healthcare systems and health research activities are geared towards profit, as opposed to other industrialized countries that are formed much more on a public health principle. It's not about what the shareholders will get in the way of profit and return. It's about how to maximize the health of the public. We don't have that in this country, and we have a structurally racist. We have a system of racial capitalism. So, I gave a little window on how the manufacturers use the image of the quote unquote safe white patient or consumer to get around the regulations on opioids and aggressively market OxyContin. And then kind of a parallel process selling the public on the idea that incarcerating Black and brown people is going to control Black and brown people and somehow minimize the risks of drugs in general. So we just have a whole century of evidence to the counter that everybody is harmed by this system, literally everybody, but Black and brown people pay first and pay the most, at least initially. I think our whole society is collapsing under these fictions, but Black and brown people are paying first, And so just to answer your question about the way that this is being spun, this is a very tried and true political strategy. When the Democrats see that they're losing ground, they step in with a tough on crime to try to rival the Republicans. And, President Clinton did this, and that really fed the mass incarceration rate among Black and brown. So the Democrats have used that tried and true strategy. And we need to do much more, first of all, to mobilize ourselves, to more directly connect drug policies and this tough on crime strategy to death rates. Because one thing that, a lot of people, including allied white Americans, rallied around the Black Lives Matter moment. But I don't think they made a strong enough connection between drug policy and mass incarceration as a racialized strategy in this country. And so we need much more direct connection between the deaths that we're seeing from substances and our emphasis on incarceration as a policy strategy. So that's the way I see the world as a physician and health-oriented, health outcomes-oriented researcher of structural racism and racial capitalism. But I would love to get Dr. Kerrison's view on how we can move forward.
How are you feeling about this whole shift that we see happening in California and now being parroted even by the president just yesterday when he was doing an interview? This notion that somehow the solution to public safety is tough on crime, which for me, I think is just coded language to, failed policies that we saw in the 1990s, policies that Joe Biden, quite frankly, spent a year on the campaign trail trying to disassociate himself from, make amends with the Black community in particular, and now seemingly is backtracking on all of that and embracing, as Dr. Hansen says, stepping into and just parroting these Republican tried and true political, I guess, talking points.
Mm-hmm. Yeah, thank you for inviting me to weigh in. I'll say to the extent to which the spin is new, or revised or resuscitated, I would argue that isn't the case, that Black pathology and the Black scapegoat for larger sort of cultural pathologies or just trends in poor health, really, prevalence of poor health, is not new. It's not new at all. To Dr. Hansen's point about sort of the arc of drug policy and our response to people who use and sell drugs with Chinese opium dens, the Mexican predator who brought in marijuana, all of this preying on middle-class white women who are subject to their own hysteria and like fragilities, these really, really dangerous, harmful tropes. It's always been somebody black or brown is responsible for it. So the spin, so to speak, I don't know is so much of a spin, like a 150, so much as it is a pivot, right? and the dog whistle, for those of us who are listening, is quite loud. I don't believe that there's a spin. What I will say, however, bipartisan, sort of a bipartisan trend, is the public safety hook, right? For sure. We have to save ourselves from, and whoever X is who X is. If we're trying to save ourselves from people who commit crimes by using conviction and sentencing, and especially sentencing to incarceration, we are in very big trouble. And I don't just mean that politically. I mean that numerically, right? So victimization surveys indicate that violent crime, property crime, and illegal drug use, very, very prevalent, again, across demographic groups. It's not an actual reflection of what we're seeing in, courtrooms teeming with black and brown folks who are awaiting arraignment, right? And also dealing with really, really high bail set. That picture is not actually representative of what we know to be true as sociologists, as demographers, as political scientists, as health scholars who actually measure victimization, okay? So if you're measuring victimization, the numbers are high and we are in trouble. The second thing I will say too, with respect to the spin, is in this moment of COVID, I think, and I'm seeing this in my own research, I do a lot of interviewing with folks who are still dealing with the fallout of having been incarcerated and with felony drug charges and tackling recovery from misuse. So that's sort of like my locus of who I speak to. But what they talk a lot about with COVID is like, this was one more thing that just swept me off my feet. And so I think a lot of people, if they're operating some of the lowest rungs of the ladder with respect to access to resources, access to care, access to dignity that's recognized by others, right? And they're feeling unanchored, these are people who are very well seasoned at struggle and survival. If they are feeling unanchored by this, I think a lot of folks are grasping at what is a thing that we can tether ourselves to and be effective at, that we can execute on in a moment of so much uncertainty, in a moment where people are looking towards their representatives, looking towards government at municipal, state, and federal levels to come in and fix something. This is a thing that people can point to, and it tracks with a very long-standing, decades-long platform of Black and brown pathology. So even if we're moving from, okay, street drugs are contaminated, they're very, very dangerous, they're located in these sorts of urban environments with Black people, that's just categorically false, because we know the large majority of poor folks in the US are in fact white, right? That Black people, the majority, are not in fact located in these urban cores. That is a complete fiction. That's a complete fiction. If you go to Ohio and West Virginia and Kentucky and Tennessee, right, if you're moving through Appalachia, that's where you see some of the highest concentrations of misuse for methamphetamines, heroin, opioids, and more recently, fentanyl, right? So even then, as we're looking across the bipartisan line, before and after the moment of COVID, wherever the location is for scrutiny and intervention, that as it stands is actually incorrect. So all of these sorts of mistakes and blunders and, okay, we tried that and this experiment failed, I believe, and the evidence suggests, that those failures are actually victories, because even when they don't work, it confirms that these people are incorrigible. They are not savable. They are so fundamentally flawed on a cellular level. These are not folks that we can save, and so they're not worth saving. And that's not a spin. That's a posture. That's something I think.
You said something really profound, or that we don't hear enough, Dr. Carrison, and that is the notion that we can achieve public safety through prosecution, and harsh sentencing. That is a narrative that is put forth by folks. It's been used throughout the decades. What is it in your research that really impacts public safety? If you're saying that it's not prosecution and sentencing, from the research that you've done, what are the drivers of that we're not talking about?
Easy. Love, in a word. So people say, okay, yeah, she's from California. No, I'm from Brooklyn, and we love in Brooklyn.
Not just California, Oakland. Okay, so
I'm in Richmond, a little different, but yes. Love is an easy answer to this. And by this I say, if we're coming in with policing and incarceration, we are too late, right? Like, forget about the fact that those responses are inappropriate and ineffective based on the numbers, right? If we have recidivism rates at 66%, that's bad. What if planes fell out of the sky 2/3 of the time? We would say something is going on with commercial travel, okay? So if people are continuing to relapse and continuing to wind up in criminal legal system supervision, particularly due to just drug use, possession, something is happening, okay? So that's the first thing, is like, we're already too late. This is a Band-Aid on a bullet wound. But I would say too, why are they using? That's the question. That's the question. And so when you get into any sort of discussion about harm, about abandonment, again, just the lack of investment in spaces, the lack of resources for care, the lack of education, right, around drugs, around safe sex and reproductive justice, around community health and well-being, right? If you start far sooner, we wouldn't see this prevalence of issues. We wouldn't see this kind of victimization. We wouldn't see this kind of harm, because these are uniquely American phenomena. There are plenty of other, Western, if you will, industrialized community civilizations, countries, where they have cities, they have income inequality and this and that, and we do not see the numbers. Not just of convictions and the lengthy sentences. The U.S. is the global warden, right? We have the highest incarceration rates. Not only wouldn't we see those things in other places, but also the prevalence of substance misuse. And the difference between substance use and misuse is the dependency and the illness, right? Yeah. And that's why it's so important for us to think about, who are we targeting? And that will dictate how we measure illness, and then we can deploy love, i.e. resources, investment, dignity, longevity in these spaces that have long been cast out as unworthy of those kinds of support. So I would say, convictions and all that, that's a reflection of policing, and policing is a symptom of social control.
Yeah.
Yes, I wonder if I could that's so well said.
Dr. Hansen, absolutely.
So well said. And I so agree. So if we look at, what does love look like when you're looking at public policy? How do we express love, meaning actual care for people's well-being? What we would have to do is stop looking at, we would stop looking not only to demonize Black and brown people, but to focus on individual level kinds of punitive measures or even treatment. I described earlier that we now have two-tiered drug policy. Okay, we still are incarcerating Black and brown at high rates, and actually certain white communities in the Appalachians, poor white areas, high incarceration rate. And if you look at what's happening there in these predominantly white states, the way that poor rights are being described sounds a lot like the way Black and brown are described elsewhere. Cultures of poverty, they have too many children, they don't want to work. It's all this individual level kind of blame of people for what they're living in, which is high unemployment, no accounting for the well-being, economic and otherwise health well-being of the community, a lot of outsourcing based on unrestrained racial capitalist impulses, a lot of outsourcing of jobs and industry. So people are living in a state of desperation. And I have colleagues in health policy who coined this term deaths of despair, and actually that term gained popularity with this report that U.S. white life expectancy, this is a report that came out just before Trump was elected in 2016, the report that U.S. white life expectancy had declined 5 years in the past 20 years, while the life expectancy of almost every racial ethnic group, they never mentioned Native Americans because it wasn't true of them, but the life expectancy of almost every other group had gone up in that period. And so deaths of despair took on some purchase once people became concerned that white people were losing ground in their health. But if we start to really look at that, then we see that what deaths of despair covers up is two things. Number one, of course, Black and brown people have been living in conditions of despair for a very long time. And white blue-collar people were protected initially by industrial discrimination. You know, Black people and brown were the last hired, first fired. They couldn't get access to union membership. And so decades prior to these white blue-collar communities that are now suffering very high unemployment, the same dynamics hit Black and brown communities. So the white blue-collar workers were just late to the party. You know, same syndrome, but they were late to the party.
Yeah.
But then also what we don't do, just very quickly to sum up, what we don't do is ask what causes the despair. Mm-hmm. It's not the individual person that's choosing not to have housing, not to have a job, not to have prospects for the future. It is the institutions and policies that are not looking out for the public good, right? That are really making it very friendly to businesses who want maximum capacity to extract as much as they can from workers here. And when they run out of that here, they move elsewhere, they move overseas. So we have to have a structural analysis. And that's why I'm so glad you started off with language of structural racism. We have to look beyond the individual and their propensity for drug use and bad choices. We have to look at how do we structure a society for well-being of society. And I think that that's what Dr. Kerrison is really leading us to. That is a loving, caring society when you're planning for economic well-being and for the conditions that are not despairing, that are flourishing.
Well, let me ask you this, Dr. Hansen. So this report that came out that now shows that drug overdose deaths amongst African Americans, particularly men, has surpassed that of whites. Where does a report like this go? I know it's been published in journals, news outlets have written about it. That's how I found it, reading an online news site. But does a report like this make its way into the hands of policymakers at the state level, say in California, or at the federal level in Washington, D.C.? What is the hope for someone like yourself who's a researcher who does this kind of critical research? Where do you want to see this report end up so that hopefully there is some action taken with respect to it?
Well, there is some hope, even though, unfortunately, the Biden administration, like you pointed out, is starting to fall back on this tried and true, let's get tough on crime discourse. There is some hope in that the Biden administration has actually placed racial justice on the map of the opioid policies that they're rolling out. How do I know this? I do serve on the National Academy of Medicine's opioid collaborative, and Rachel Levine, the Associate Commissioner for Health, and also the CDC leadership come to these meetings. And so we're reviewing this kind of research and being very explicit that deaths of despair, if we reorient towards, well, what are the social and structural drivers of these deaths? It's not just white people, it's Black and brown people. So we have to be very deliberate. We're not just talking about economic development in white communities. It has to be across the board if we're going to take deaths of despair seriously as a frame. So that has made it into the White House discourse, into the CDC discourse, into many of our, and NIH is also acknowledging this. So I think it's getting there.
Specific that has come out of these meetings? Are there any, action items that you can point to that have come out of these meetings?
I would say it's early yet in terms of the details of how this is going to play out in the opioid plan. I think there's a commitment to strengthening public health institutions. So strengthening harm reduction, for example, making it easier for organizations that do syringe exchange, for example. They're not quite there yet in terms of what we call supervised injection facilities or overdose prevention facilities, where people can use drugs with medical assistance and supervision, which has actually been shown to dramatically decrease
wasn't there, Dr.
overdose death rate.
Big headline about the Biden administration using federal funds to provide, a safe, clean needles? I forget the headline. I'm sure you're familiar.
Yes, so that's where we gotten more traction with things like needle exchange, syringe exchange and needle exchange, and naloxone overdose reversal kits, making those much more broadly accessible. The administration is shy about things like these supervised consumption rooms, safe injection facilities, overdose prevention facilities, because it's a political time bomb. There are lots of people, but they are permissive. So New York State has passed laws legalizing it. There are other states soon to follow. And the Biden administration has generally not gotten in the way of that and has advocated for studying it closely, so to see whether the results are good from that in terms of overdose death rates. There's a push from the Biden administration to expand access to drug treatment, to addiction treatment through the public systems, and to subsidize things like buprenorphine medication that actually was introduced and legalized by Congress in 2000, specifically for the quote unquote suburban opioid problem. So it was envisioned as something to address the needs of white Americans. There's more attention to expanding that so that Black and brown people with public coverage can get access to that. What we're still missing, though, is a really structural analysis linking the fact that we're not providing for any alternatives to incarceration. We're not providing for jobs. We're not providing for housing. We really have to move to that level of what we call social determinants of health or structural drivers of health. Mm-hmm. And so I and my colleagues are lobbying very hard to show that if we really want to get results, that's where we have to operate. We have to do, as Dr. Kerrison is advocating, we have to express care for people in that kind of addressing of root causes. Mm-hmm. So I would say we're very much in the middle of negotiating with the federal government about the terms of the opioid policies and addressing structural and social drivers. And that's why it's so important that listeners to this show understand the power of their organizing and their weighing in on this. The Biden administration wants votes. They want, so they're sensitive to, well, what is the electorate asking of us? And that's where all of us have to step in and say very loudly, we choose life. We choose love, we choose systems that will enable the survival of our country, including Black and brown people, So that's where we have to really weigh in and give them some support and direction to do this and not to fall back on tough on crime.
And I'm glad to hear that there is some effort afoot, and the Biden administration has made racial justice in drug policy a big part of their administrative kind of efforts. So I'll just ask you, Dr. Kerrison, in closing, has anything happened in the state of California that you are aware of that approaches what you believe to be are equitable policies around drug use? And how will this information coming out of the UCLA, you think, impact what California is doing now that we have these numbers that say Black men are in crisis as it relates to drug overdose deaths?
Yeah. Well, I will say I am, and I would imagine Dr. Hansen is as well, in a really unique position as professors in the UC system, because we are linked up. It is expected, right, that we operate as public scholars, which is to say we do things like come to, answer invitations for the Areva Martin show. I have sat with California Senators Assembly. I work with Shirley Weber. I've worked with Barbara Lee. I've worked with the Black Caucus. And I would say those relationships are very fertile, right? I take advantage of that. I'm very, very lucky in that those partnerships are already sort of installed. But what I would say are victories is the fact that the questions on the table, right? That the bills are getting written, right? And that they are passing, just 10 years ago with realignment, which basically took so much of the responsibility of prisons to deal with convicted folks, moving it to the county level where there's no space for this. That came out a lot of research. A lot of that came out of research on recidivism and prisoner reentry, right? And so moving now in this space, the research sort of life cycle takes a little while. So some of what's coming out, Dr. Hansen's work is at the cutting edge and really in the beginning of sort of what we will see. And as we come up with these fundings and interpretations, and they are robust and sound and triple checked, and somebody else kick the tires on them too, because we don't rush, then I believe we will see a lot of interventions that are evidence informed. So for right now, I know researchers need to be supported in that work. One of the other things I'll say that's a great place to be as a professor is teaching students, right? So if we're thinking about the informed electorate, if we're thinking about the public will, there is nothing better than holding 150 people hostage for 15 weeks. You are going to listen to me, friends. And that's one of my greatest privileges, is teaching students. So there's a big rallying cry. We are not a small group, right? This is a non-trivial lot of folks who are loud, right? We're not going anywhere, and you plant your seed and someone else comes along and tills it. It's a long game, and one that I'm so excited to be part of.
I'm so glad you said that, because when you think about dismantling systemic and structural racism, sometimes you get discouraged when you're looking at the Mitch McConnells of the world, the folks that have been in politics for 40, 50 years and who are obviously more interested in maintaining the status quo. I can imagine as a professor, you gain a lot of hope by looking at that next generation, those 18, 19, 20-year-olds who are learning that it is okay to acknowledge that systemic racism is a real issue in America. We don't have
that
to shy away from that we can embrace that. It doesn't mean little white kid go home and cry and feel bad about yourself. That's not the goal.
We're not doing that. Yeah, but that's not productive.
Yes, but these are going to be the leaders in our U.S. Congress and our U.S. Senate and in the White House and in our state houses around the country.
That's right.
And that there's hope that these young people are learning that these problems exist, and then they're learning how these problems can be solved. Thank you so much, both Dr. Hansen, Dr. Carrison, for the work that you all are doing, and that you see it as a privilege. Because yes, pouring into the next generation, I think we all have an obligation from wherever we sit or stand to do that. And there is hope when you look at young people who, are rejecting a lot of the policies that were enacted in the 90s, even going back before the 90s. So I'm encouraged. You guys give me a lot of hope because you are hopeful with that next generation of students. So again, thank you for your great work, and thank you for joining me this morning.
Thank you.
Wow, this has been such an interesting conversation. When you think about U.S. drug policies and how policies have discriminated against Black and brown people, and how differently Black and brown people who have addiction are treated in this country. And it's so fascinating to hear Dr. Hansen talk about the opioid crisis and how big pharma marketed its drugs to middle-class white women, and how our country allowed them to do so. And rather than punish those users, those end users, those middle-class white women, they went after big pharma. And you compare that to Black and brown people in urban communities who are using cocaine or heroin, and how the response from our criminal justice system was to go after those end users and not the folks who were supplying it. So
yeah, that's so well put. And one thing we didn't even get into was this idea of reparations, because we're in the era of white reparations, basically. These corporations, a lot of the activism around getting these settlements was from white communities. And for the most part, a lot of the money is being put into those communities. And what we don't talk about is all of the decades to a century of drug war style policies, punitive policies that have ravaged Black and brown communities, and the reparations really that are owed them as well. So that's something we could have gotten into, but we didn't. But you're so right that we pivoted to the pharma companies. But to be honest with you, there hasn't been any substantial change in the legal and policy system that allowed the pharmaceutical companies to do what they did and to run off laughing with the majority of the profits. They knew they were going to be sued. They set aside money for these lawsuits. It's just a little drop in the bucket compared to the money they made. And really the problem is our for-profit healthcare system and totally unregulated pharmaceutical industry, that's based on racial capitalism. It's a very racialized industry as well. So we're not even touching that. That's where we need.
Dr. Hansen, and that reparations issue, I'm proud to say that California is taking the lead on reparations and has established a whole commission that is studying reparations and have already gotten to some recommendations that they presented to the California state legislators, who will be considering if reparations should be paid to descendants of slaves in the state of California and what those reparations should look like. So proud to say that California is leading the way on that. Just some words to live by before I get out. And those words, we've been talking about all week is vote, 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 vote. And when you vote, you are using your voice to take a stance and a position on these really critical issues. And if you don't vote on Tuesday, you can't complain on Wednesday. Be safe out there and remember we're all in this together.